Medical ethics often sounds like something we dreamed up very recently. For one thing, most people encounter it chiefly through whatever current controversy is making headlines. Right now, we have selective reduction by abortion of drug-induced multiple pregnancies. We have genetic testing and genetic therapy, and most recently, the possibility of human cloning, with all the fears it raises about genetic engineering techniques being applied to humans in ways that evoke Brave New World and similar nightmares. And we have the current controversy about physician-assisted suicide, which is just the active euthanasia debate with a new name, as the Supreme Court has issued its review of the decisions of two lower courts, which would have asserted a constitutional right to suicide. This last question is in turn a spin-off from, and is often confused by, the broader related questions of when and to what end we should use advanced life support techniques and technologies. All these are questions which have arisen and could have arisen only in very recent decades. But in truth, medical ethics is as old as medicine, and in fact substantially older than what we would recognize as medicine. Medicine in the modern sense of an empirically based and scientifically founded and measurably successful intervention in human disease and dysfunction. Way back when surgeons were still doubling as barbers and still being paid in chickens, as famously Socrates on his execution leaves instructions to pay a rooster to his faithful physician, way back when you had a slightly better statistical chance of survival if you couldn't afford a doctor, there was and I won't comment about the degree to which that might pertain today, there was already extensive instruction and reflection about the obligations of doctors and the relationship between doctors and patients. Perhaps the antiquity of this body of reflection, a piece of which is captured in the Hippocratic Oath, still sometimes in use today, helps to explain the power of a certain moral view of medicine, which we as a society continue to honor even as we recognize that it is being pressed out of existence. This is the model which sees the relationship between doctor and patient as a relationship of personal trust and individual loyalty. This is the view presupposed in those discussions which speak of the covenant between doctor and patient. According to this conception, adapted from the Old Testament account of God's relation to Israel, the physician stands in a fiduciary relationship with patients as one entrusted with responsibility for their well-being. Justice on this model is done when the doctor rightly fulfills her or his responsibility to act as patient benefactor, protector, and advocate. By now, you should all be picturing Marcus Welby or somebody very like him. Both for its theological grounding and for its exalted picture of the virtue of human fidelity, this is a very attractive picture and one that continues to instruct us. But it would be a mistake to imagine that this model of healthcare and the delivery system that embodied it did not have its own structural problems and its own characteristic failures. To begin with, the modern version of its theory is highly individualistic, treating the doctor-patient relationship as essentially dyadic. The physician is left to determine the patient's interests largely on his or her own, although in accordance with broad standards of practice. On the other side, the patient and her or his interests are thought of in isolation from the other people and relationships which make up the context of human life and provide so much of the content to our experience of illness and recovery. Such a model can distort and obscure crucial dimensions of what is at stake, both for patients and healthcare providers in the giving and receiving of care. In its focus on individual doctors and patients, this understanding of healthcare may also be characterized as privatized. The provider in the contemporary world has been seen as a separate actor, and the beneficiary as a single recipient of care, rather than seeing the work of the physician as representative of a broad social ethos, and seeing medicine as a social enterprise, relying upon the contributions of all members of the society and directed toward a well-being in which we all have a stake. The individual and private construction of health care and caregiving might be unproblematic in some contexts. Indeed, it has the strengths that go with its weaknesses in its emphasis on the personal nature of health care and the human particularity of both doctor and patient. But what the model makes invisible is still a reality. Under the fiduciary and covenantal model of health care, despite its appeal, there was still a kind of rationing of access to care, according to the blunt instrument of who could afford to see a doctor. Another level of selectivity occurred when doctors simply did not prescribe modes of treatment for which a particular patient lacked the resources. Now, the edges of this de facto rationing were softened by personal and community connections some of the time, as physicians made private accommodations for members of the community who could not pay for needed treatment. But clearly, optimal treatment was not universally given under this model any more than under alternative constructs. The poor were undertreated then as now, and there were and are incentives for and instances of corruptions of this version of the doctor-patient relationship. For example, in the prescribing of unnecessary drugs and procedures, and especially in instances of unjustified paternalism. We must not forget that it was under this model that the compulsory sterilization of the retarded was argued for and in fact practiced. The weaknesses of this personalized moral model are the flip side of its strengths. It depends upon the quality of an interpersonal professional relationship as the mediator of justice. And its focus is narrowed to the patient who has come under care in contrast to other actual or potential patients. Nonetheless, both physicians in their training and patients in their understanding of what they do when they seek treatment frequently still operate under this picture of the doctor as a personal caregiver, committed to the individual patient's welfare above and in despite of every other thing. Let's talk about some history. In the decades of the 1930s and 40s, health care financing in this country moved from almost exclusively private fee-per-service arrangements to include various types of health insurance. The newly created social insurances of Medicare and Social Security disability and veterans benefits and the like, and the proliferation in the 40s and thereafter of the private health insurance market that was part of the growth and ascendancy of corporations. Both of these permanently reshaped the landscape. During this historical transition, the ethical model for practice and the moral assumptions that accompanied it did not change very much. But the realities underlying the health delivery system and the constraints operating within it changed quite a bit. Now we had insurance companies deciding, not without medical advice, but obviously with a non-medical agenda, what was a normal and appropriate standard of care and what was extreme or experimental or not indicated. The same companies exerted direct pressure on the cost of treatment as well by determining what could be reimbursed for a particular service in a particular region. Even more fundamentally, with the rise of health insurance, the ground of assessment of suitable treatment shifted from individual to group, mediated by actuarial analysis of costs and risks and distributions of need. This is a crucial shift in the meaning and the determinants of justice. But much of this was hidden and most of it passed without serious public comment or debate, or even public recognition. You still went to your doctor and handed over your Blue Cross card or whatever, and he, usually it was a he, decided what treatment was indicated, and that, as far as you were concerned, was that. But in fact, it wasn't that, as the faster than inflation rate of healthcare cost increases soon made clear. Suddenly, starting about 20 years ago, health insurance and its costs and its terms were on the table in employer-employee negotiations over contracts and compensation. Along with the escalating shift to group health coverage, complaints began to be heard about what insurance companies would or wouldn't cover and whom they would or wouldn't accept as a subscriber. At about the same time, universities, large employers, and other groups began to find it cheaper and more efficient to manage their own primary health care providers without referencing as necessary for special needs. This was the context in which health maintenance organizations and managed care plans made their appearance under the financial pressure of institutions being unable to meet or to control the cost of the health care they needed to provide for students or employees. Now, it must be said that these innovations in financing and delivery systems achieved many of their aims. In those initial settings, membership in the sponsoring institution determined coverage, and a covered population of full-time active employees and full-time college students ensured a relatively young and healthy group upon which to practice the principles of health maintenance, preventive medicine, and early intervention. And for the most part, they worked very well. Per capita costs went down, and patient satisfaction was generally high. But immediately there was a different kind of rub, as physicians began to chafe at it being expected to see more patients per hour, to account for their time and their prescriptions and the tests they ordered. Already, there was a new layer of management accountability, where diagnostic and treatment decisions were questioned not by other physicians, but by efficiency experts and accountants and financial officers. This, physicians and other caregivers felt, this was an intrusion into the practice of medicine itself, and it affected not only their professional autonomy, but the quality of patient care. More fundamentally, we might say, it created moral confusion and ambiguity, as it placed doctors and other caregivers in a situation where their loyalties and their responsibilities were divided, and their internalized norms regarding the moral practice of medicine could not be applied without revision. On the one hand, they still had the privileged relationship with patients and the duties it entailed. On the other, those patients tended to come and go rather quickly, as their relationship with the sponsoring entity was usually temporary. For caregivers, their employer was no longer the set of patients who constituted their practice. Now it was Yale University, or Community Health Care Plan, Inc. And that employer could and did place constraints on what care was delivered to whom and how, demands that doctors and nurses had to meet. When those demands conflicted with what the caregivers thought of as appropriate care and obligatory professional conduct, it created tensions and moral crises for the medical staff. How acute and how pressing those have become, Barbara White articulated for us last night much better than I can do. The old understanding of justice as the fulfillment of a fiduciary relationship between an individual patient and his or her physician was under assault. But tempting as it is to regard this straightforwardly as the intrusion of crass financial concerns into the pure moral realm of medical practice, this is not an adequate construal of the problem. remember that HMOs and managed care operations arose because of a significant degree of failure in the old system. A system of health care in which an ever-shrinking proportion of relatively affluent citizens can afford a dedicated personal physician to protect their interests is not necessarily more just than one in which more people have access to more limited forms of health care. There has always been a mechanism for distribution, and large-scale funding decisions, macro allocation as the phrase goes, have always, directly or indirectly, affected small-scale or micro-allocation possibilities, like whether Aunt Lily gets her hip replacement or not. The rise of managed care and the development of for-profit hospitals have just made more direct and more visible, and thus more open to scrutiny and more troubling, a set of moral and social problems which are endemic to the application of finite resources to needs that have and will always outstrip them. Nor is it concern for the economic viability of institutions that provide health care a non-moral concern. When city hospitals are forced to close because they lack operating funds, poor and vulnerable populations in areas that are already underserved have that much less recourse for treatment. The bankruptcy of San Francisco General is a moral disaster as well as a fiscal problem. And in asserting an ethic of care, we cannot wash our hands of questions about what care we can afford to give to whom and how we are going to pay for it. But as more and more diverse groups of citizens have moved under the umbrella of managed care, a trend that is bound to continue as we experiment with HMOs for Medicare patients, the difficulty and the moral ambiguity of the allocation and access decisions these systems will have to confront become ever more apparent. The question is not whether we will make painful and difficult allocation decisions, including decisions to deny care that might be beneficial in order to provide some other care to someone else. The question is who will make them and how will we make them? And according to what version of justice will they be made and defended? It is here that Christian convictions and the understanding of justice that they shape have an important and distinctive contribution to make, both to the moral formation of Christian healthcare providers and administrators and to the wider public discussion. Okay, we're going to shift gears. The general theological foundations of justice and Christian thought are threefold, Trinitarian as it were. First is the lordship of God over all creation and God's claim of final ownership over all the material resources over which we act merely as stewards. Thus, God's will for the distribution of the means of life is the ultimate ground of justice. Second is the basic equality and dignity of every human being founded in their common origin and their shared status as bearers of God's image and subjects of God's care. Thus, every person has, as a matter of justice, claims against attack, claims to fair treatment, and claims to an equitable share of the resources which God provides for the well-being of all. Third is the gospel's demand that our treatment of one another imitate and reflect the graciousness of God toward us, revealed preeminently in the grace of Jesus Christ. Our understanding of what we owe to one another is decisively shaped by the consciousness of the enormous debt in which we all stand before God. All of which is to say that the Christian idea of justice is firmly rooted in the story of the church, in Scripture which forms the church. And that has a marked effect on what versions of justice we may embrace. The first point to note is suggested by contrast with my earlier observation about the individualism and privatism that has characterized the understanding of justice in medical care in recent decades. This is that the biblical picture of life is social at its very heart. The human person comes into being already in relation, and all dimensions of moral life, including the individual's relationship with God, are seen in terms of their impact upon a community. Justice, as described in the Old Testament, is thus a feature of interpersonal relationships. It includes such obligations as truth-telling, fair dealing, and the avoidance of harm, as well as positive duties like loyalty and gratitude. It is also, however, a feature of much broader social relationships and of the structures which mediate and regulate them. The prophets do rail against the acts of individuals in using fraudulent weights and measures or accepting bribes, but they also condemn broad social and economic practices. The covenant constrains such things as lending at interest, keeping garments in pledge for debt. It even regulates the harvesting of produce. Such legally permissible activities as acquiring mortgaged land when their owners fall into hardship are condemned as unjust, as contrary to God's will for righteousness and equity. Remember Isaiah's, "Woe to those who join house to house and vineyard to vineyard." This is all lawful. It is still condemned. And in the end, the nation of Israel is dragged into exile for refusing to observe the covenant's provisions for the support of the poor and the protection of the vulnerable. So the Old Testament condemns not only unjust acquisition of goods, not only their unjust use for such purposes as subverting judicial proceedings, it also condemns great disparities in distribution and condemns ignoring the dire needs of the poor as a violation of God's will, as an offense against God's continued claim upon the goods of the earth, intended for the support of all. And this exerts a powerful egalitarian pressure upon the concept of justice. It makes it clear that justice concerns not only the elimination of force and fraud, but also the provision of basic needs on an equitable footing. And the New Testament continues this tradition. If anything, the demand for universal attention to human need is intensified as one of the hallmarks of the Messianic age. In particular, the physical needs of strangers and enemies are to be provided as a sign of the universal love of God, and the care of the sick is expressly one of the tests by which fidelity to the kingdom is judged. To put it a little more provocatively, those of us who present ourselves as beggars at God's door, asking for a mercy we have no claim upon, had better be very careful about how we respond to the beggars at our own doors, whether at home or in the hospital. Overall, the Bible makes it clear that equity in treatment, procedural equality, and the just distribution of the things that all need to live are aspects of God's reign over the world and obligatory for God's people. What does such a tradition about the meaning and the scope of justice do to shape Christian reflection about the meaning of justice in healthcare? The first thing to be said is that all discussions of justice in healthcare in this country must founder on the reality that, nearly alone among the industrialized nations of the world, the United States does not provide universal access to basic health care for all its citizens. Every other mention of just policies and equitable procedures must be qualified by the acknowledgement that millions of Americans have little or no recourse for treatment unless they reach a public hospital in a condition so severe that death is imminent without care. The unlucky ones die anyway. The others get whatever treatment the hospital can afford to give them and are released as soon as their condition is stable. The fact of those excluded from the healthcare system hangs like a shadow over all subsequent discussions of what constitutes just treatment for those who make it in the door. There is no theoretical answer to this problem because the lack of universal health care access is not a theoretical problem. It is a problem of political will in this democracy. 3 years ago, the nation demonstrated that it was not ready to pursue this difficult social and political task, deferred since the days of the New Deal. Until we as a nation demonstrate this resolve, all our discussions of justice in healthcare have a touch of unreality about them. Nevertheless, most Americans are insured through one mechanism or another. Most have access to basic health care or more, and questions still remain about how we allocate the resources we have among the patients we treat. I'm going to finish by making a few concrete suggestions about what criteria do and do not have a place in those decisions. In sketching the history that has brought us to our present quandaries, I've tried to suggest that economic viability and efficient distribution of resources are themselves moral concerns, matters of moral prudence and responsible stewardship. But this raises a basic question. How do we pay attention to those things without violating each other's trust in the seeking and the giving of care? I have also criticized the narrow focus of the recent model of justice in healthcare, which ignores the broader social dimensions of justice to focus only on its interpersonal dimensions. But this too raises a question. How do we widen the scope of our concerns from the doctor-patient dyad without abusing or reducing the intimacy and the power of the privileged relationship between caregiver and patient? It is probably an occupational hazard for an ethicist to suggest that we begin by thinking more clearly about the issue at hand, but that's what I'm going to do. It does seem to me that our first task is a conceptual one. Christian commitments to the basic equality of all persons compel us to examine our procedures and our policies, to root out as much as we can of the biases and the distortions which characterize our culture and distort our judgment. We live in an age which values economic productivity almost to the exclusion of every other good, in a culture which worships youth and beauty, and which is prepared to engage in some flat-footedly utilitarian calculus about whose life is worth saving. Against such temptations, Christians must declare that all are cherished by God and all have an equal intrinsic claim on life-saving resources. To honor that claim, we must distinguish more clearly and more reliably between medical and non-medical criteria for treatment eligibility or for priority in receiving scarce resources. Partly, this entails recognizing that there is some vagueness to the distinction, as when a candidate for treatment is judged in terms of the quality of the benefit or the degree of social support they are likely to receive. Such judgments are not simply clinical, as they cannot be cleanly separated from beliefs about what constitute valuable life activities or what kinds of relationships represent adequate social support. Because of such ambiguity, using such criteria risks involving us in indefensible judgments about the value of other people's lives, judgments we have neither the authority nor the wisdom to make. However, it may not be possible to exclude absolutely such considerations from allocation decisions. Responsible use of scarce resources requires that they not be wasted. If they cannot provide substantial benefit, if they cannot be effective in a given situation, then they should, in justice, be used elsewhere. But the use of such criteria represent a terribly problematic human enactment of Jesus' word that to those who have, more will be given, and to those who have not, even what they have will be taken away. Only large and certain and irremediable differences in quality of benefit or degree of support should affect who receives scarce resources. Similarly, I find large differences in likelihood of benefit a just and reasonable criterion for the distribution of scarce treatment. It is a way of respecting life by seeing that resources which could be used to save it not be expended uselessly. But such judgments must be made on clear and applicable medical criteria, and in view of their uncertainty, they should only influence allocation when there is a dramatic difference in the probability that one patient will be helped by the resource. Here I want to make some cautious remarks about patient age as a criterion in allocating inherently scarce resources. Unlike some of my colleagues, I am prepared to see giving preference in certain forms of care, organ transplants, for example, to patients under a given age as a matter of giving people a more equal chance at a normal lifespan, rather than as a means of prolonging life at every point whenever possible for as long as possible. I regard this as an appropriate social goal that's consonant with justice and also consonant with the Christian acceptance of mortality as a reality of life under sin. In all these cases, I've been talking about criteria for making decisions about which of several patients receives a life-saving resource. These are issues of microallocation. Such decisions must be vigorously protected from the crude cost-benefit analysis that is prepared to make an individual's survival contingent on what comes down ultimately to market value, how much their care will cost versus how much they contribute of what the culture values, which in our world comes down to a rough estimate of their future earning potential. This willingness to make comparative judgments about the worth of individual lives, the basis for the distribution of treatment, is insupportable, both inimical to the fundamental commitments of medical practice and an offense to God's sole sovereignty over life. We are simply not authorized to make such judgments about one another. Against them stands the warning, who are you to judge another's servant?